We're very, very happy to have you on the call today. Today we will have a presentation by Rear Admiral Christine Hunter. She is the director of the Tricare healthcare system for the military. And just a little background information, Rear Admiral Hunter is a graduate of Boston University School of Medicine and has practiced in internal medicine, hematology, and medical oncology. During her 29 years on active duty, she served as commanding officer of Navy West and Naval Medical Center of San Diego, chief of staff of the Bureau of Medicine and Surgery of the Pacific Fleet Surgeons. She's the commanding officer of the hospital in Bremerton, executive assistant to the Navy Surgeon General and director of medical services at the Naval Medical Center in San Diego. Her military decorations include the Legion of Merit, 6 awards, the Defense Meritorious Service Medal, the Meritorious Service Medal, the Navy Commendation Medal, 2 awards of that, and the Navy and Marine Corps Achievement Medal, 2 awards of that. That means that her uniform is very heavy. We're honored to have Christine Hunter as well as Dr. Kubler, who is also the Chief Medical Officer of Tricare, join us for this presentation. I want to let you folks know that we will have a Q&A session in the end. There's a box that should be on your webinar screen, and you can type in questions in that question box. So without further ado, Rear Admiral Hunter, thank you so much for joining us today.
Well, Leslie, thank you for that kind introduction, and it's certainly our pleasure to share our Tricare and military health system experience in our journey toward the patient-centered medical home on behalf of our patients. So if you'll advance the next slide for those who are following on slides. We often get questions about who do we serve in Tricare. Sometimes people think we serve only military active duty, but in fact we take care of military active duty, their family members, those who have served a full career in the military and retired, and their family members, and also our seniors in a program called Tricare for Life, in which Tricare serves as a supplement to their Medicare coverage when that's applicable. And altogether we have 9.6 million beneficiaries. And 5.5 million of them are enrolled in our Tricare Prime program. So that's our managed, enrolled, PCM assigned program, and those would be the primary patients we are targeting for medical home. We have 2.1 million who are in what we call our Tricare Standard, where Tricare serves as an indemnity program and is paid fee for service. And then we have a variety of other programs that patients may use, including programs for reserve and guard. And if you read the papers, you'll certainly see that we've tried to pay a lot of attention to the medical and behavioral health needs of reserve and guard over the last few years. So that gives you a little sense of our numbers of people. For those of you who think in terms of numbers of encounters in a very large system, scope and scale has been one of our biggest challenges here at Tricare. So I like to cite a couple of weekly numbers. We have 2,400 new babies born in our system every week. So those are 2,400 new enrollees, even if we don't do anything but sit here in our offices and not gain any more patients. That's about 1,000 of them that are born in our 59 military hospitals, and about 1,400 of them are born in private sector care, where we purchase the care through a series of network arrangements. There's been a lot of interest in behavioral health in the military, and certainly we're interested in the concept of embedding behavioral health in the patient-centered medical home. We won't spend a lot of time talking about that today, but to give you a sense, our military leaders have encouraged service members to come forward if they or their family members are experiencing stresses related to their deployment. We're very concerned about suicide risk. And we altogether have about 233,000 behavioral health visits a week. We also have a pretty extensive pharmacy benefits management program and all of our patients have free or greatly reduced cost prescriptions. So they have access and they can get their medication. So that kind of forms the baseline. We do work with the VA, but we are a separate system than the VA for those of you who had questions about that. And some patients have eligibility in both systems, so there's a collaboration. I'm getting a lot of feedback here. Perhaps moderators can interrupt. Much better. Thank you. I'm now on our overview slide. We'll talk a little bit about what prompted us to make this change to go toward medical home, our implementation in our 3 services, the Army, Navy, Air Force, and the Navy covers healthcare for the Marine Corps, and the Coast Guard is a partner in our Tricare efforts, although they're not administered through the Department of Defense. We'll talk about how we're measuring success, where it's working and where we still have some challenges, and then how we plan to move this initiative into the care we purchase, incentivizing private sector care partners to work with us and our way ahead. Go to the next slide. And this slide is our military health system quadruple aim. Many of you may be familiar with the Institute for Healthcare Improvement or Dr. Berwick at CMS talking about the triple aim, better health, better experience of care, and responsible management of the cost. As we sought to align our efforts in the military health system, we felt like we needed to do all those things, but if we just did all those things, we wouldn't be meeting the full need of why the military has its own health system, and that's because we're here in support of the readiness mission. So we have to be ready to help people prepare for deployment and to survive and thrive on deployment. We have to be ready to go with them to provide that casualty care on the battlefield at a moment's notice. We have to take care of their families so that they can be unencumbered by those concerns while they are serving. We need to look to the behavioral health of service members, their families, and our own caregivers who are experiencing quite a bit of exposure to very devastating injuries on the battlefield. And we need to reinforce the professional competency and currency of our team by providing a full spectrum of practice, or sometimes that's referred to as working at the top of their license, and we need to reinforce that. So we see all of these issues, the improved population health, the excellent experience of care, and the responsible management of the cost as supporting our core mission of military readiness. The next slide has that quadruple aim in a bit of a vice clamp, just sort of showing you that we, like all others, are under considerable pressure now to take a look at all aspects of our healthcare system, delivery modes, what care costs, do we achieve the best outcomes, the pressure to add additional benefits, and to deliver on behalf of our patients. And so all of the things that those of you who are listening in other health systems are dealing with either affect us directly, or we have a Department of Defense equivalent. And I'm going to in particular talk about some of the satisfaction and increased utilization issues that pushed us toward medical home as our preferred model for care. Go to the next slide. One more. Okay, great. It's just changed for us. So you should be looking at a patient satisfaction slide. What this graph will tell you is that especially patients receiving care in our direct care system were not expressing satisfaction with their health care or with their health plan to the degree that we would like. Some of this is sort of the inherent transient nature of military families, so that it's difficult to settle into a medical arrangement if you're moving every couple of years. Life needs shift. It's harder to form a relationship with a provider. And remember, many of those providers and support staff are also in uniform, and they are rotating with that frequency. So our patients expressed to us that some of the drivers for their satisfaction were a lack of continuity and predictability in the healthcare system, and a difference from location to location, that one needs to learn the nuances of a medical practice and the way healthcare is accessed in a particular area, and then soon something was changing or you were moving again. So those were some concerns. Getting appointments and having to do with how one accessed the system locally, waiting times in clinic, flow issues. We had tried a number of things like open access. Finding parking was kind of a chronic issue on military bases. And specialist availability, I think, has more to do with expectations. As patients expressed to us, circumstances under which they thought they wanted to see a specialist and that opportunity was not made available, rather than the absolute inability to find or recruit specialists. So get a little sense for some of the issues that they were experiencing in satisfaction. We also had seen our overall healthcare costs grow, and you'll go to the next slide here. Almost any newspaper you would pick up when Secretary Gates was talking about this, talked about as sort of the employer perspective, how much he was spending on healthcare. And when we dissected that, we certainly saw, well, one of the issues was we have so many more people. So our system experienced extremely rapid growth from 2007 forward to 2010 of 400,000 new beneficiaries added to the system because of the expansion of the force, the expansion of the use of reserve and guard on active duty, and when they come on active duty or are mobilized, they qualify for our benefit. And then also the growth of a new retiree population, people who would not have stayed for a full military career had it not been for the combined factors of the war and the poor economy. We also, over that time, saw some expansion of benefits, and that, we think, convinced people to use Tricare instead of other alternatives they might have had with a employer-sponsored health plan after retirement, for example. So come back to Tricare because it offers pretty good coverage, so we saw an increase in users. And then we also saw an increase in utilization. Some of that care is driven by administrative requirements. We have a lot of pre- and post-deployment screening visits that we have now incorporated into care pathways. But also, existing users were consuming more care in an absolute way. Orthopedics, we see musculoskeletal injury right behind OB as our number 1 and 2 product lines. Behavioral health increasing for reasons that we already touched on. We encouraged people to use that care. And then we had a significant issue with overutilization of the emergency room for what we'll call primary care sensitive conditions, conditions that could have easily been handled in a primary care clinic. And our struggle with that is that our patients do have access. And so there are factors to career families who have some concerns about making it to work all day, children in daycare, those sorts of things that we think influence the use of emergency room care even when patients have alternatives to that. Or they may find the military care originally was all built on a sick call model where people showed up and waited, and that's kind of culturally reinforced with the junior troops, and so they learn that you're supposed to show up for on-demand care, and then when we try to move them into a model of arranged care with asynchronous communication, there's still that habituation to on-demand care, and ERs are one way to get that. So we do have some issues with ER utilization. Many of them are children less than age 5, and although we have arrangements with many urgent care clinics, we find that they're not always willing or don't have the providers able to see children under 5. Just a quick refresh on our demographics on the next slide. I apologize, this slide is a little out of order, but you will see that we do have a fair mix of gender and age range. And again, many people don't think of that when they think of a military health system, so you'll have an opportunity to look at that. So with all of those things as background, we looked at what are our models of primary care, what's worked and not worked for us. We decided that it was important for us to reinforce a primary care-based model, and we, in 2009, selected the patient-centered medical home as our preferred model for care, beginning at the military treatment facilities for our enrolled patients. And I'm going to let Dr. Kugler talk through the next couple of slides and talk to you about how we issued the policy and how we selected an NCQA standard, and then I will come back in probably about slide 16. So, Tom, why don't you go ahead?
So we have had an existing policy called the PCM by name ever since Tricare started in the late 90s, but we found that when we were evaluating all the issues that the Armel talked about earlier, that there was a gap in delivery on our policy, and it was this time in 2009 the leadership felt that we needed to re-energize that and redefine it in the setting of the paradigm in a medical home. So what's described in this slide is basically a policy that was signed at that time. Actually, the work and discussion was 2008 through 2009, culminating in that signing at that time. And basically, the major points are that it incorporates the principle of the medical home as the foundation for our primary care delivery model within the MHS. Restates that our access standards that we already had codified basically within our policy, that be re-energized, and we clarified a definition of a primary care provider, and the requirement that that primary care provider also deliver their care in the context of a team. Emphasize the importance of communication for not only our beneficiaries, but for all the other key stakeholders about the medical home, especially our providers and line leadership. That we would, as we transform the system, look at ways to keep ourselves accountable in that transformation process, and that felt that policy needed to be hinged upon the performance on specific metrics. Again, key to those elements of the quadruple aim that we talked about earlier, and that were linked to the medical home, and that's satisfaction, access, continuity, and quality. And then finally, that there be a governance process for monitoring now through our existing, at least at the DoD TMA level, clinical quality forum, one of our clinical integrating councils, the clinical steering committee, and our executive council, which is basically the senior medical advisory committee. That's our 3 service generals, our deputy assistant secretaries of defense for health affairs, and so forth. So the next slide just talks a little bit about the governance. That this has evolved into a very major strategic initiative for the MHS. It has ongoing visibility at the most senior level of leadership, both within the healthcare side, but also with our bosses within personnel and readiness within the Department of Defense. We have an advisory board. It's a tri-service made up of the representatives and their leaders within the patient-centered medical home within the services, as well as representatives from our Tricare regional offices that monitor the work of other working groups that have set about executing this policy. And this advisory board meets monthly, monitors this work, and reports to senior leadership. Working for that advisory board is a subordinate working PCMH working group, which meets monthly and works specific issues dealing with the specific execution of the medical home. The next slide talks a little bit about service implementation. This has been like I've never seen anything else in my career in the military. One that's been adopted in very uniform vigor and enthusiasm among the 3 services. Each of them have issued operational orders, kind of unique to their own command structure, but all unified by the principles of the medical home. The Army's calling us the Army. Actually, it should be Army Medical Home. And Navy Medical Home Port, and the Air Force initiative currently being called the Family Health Operations Initiative. All these are basically their initiative names for the implementation of the medical home within the specific services. Right now, our practices in the direct care sector are our primary care platforms are primarily pediatrics clinics, internal medicine, family practice, primary care, and undersea and flight medicine sites. We have patients that are enrolled specifically at those sites. They share common, and the intent of the medical home is to get them to share common policies, procedures, and guidelines, and have similar teams that in construction and an emphasis. Right now, we have at least 400 plus and plans to be up to 430 practices within the three services, 180 in the Army, 107 in the Navy, and 140 in the Air Force currently. Various sizes, but typically anywhere from 2 providers per practice up to 5 providers or FTEs, depending upon the setting. Try to limit it at no more than 5 so the practice can get a handle on its population and the patients can have a continuity among a small group of providers. Next slide. Talk a little bit about the plans to implement it across the system. We did choose, and I'll talk about this in a minute, we did choose the NCQA as recognition process as a way, as at least a guidepost initially to measure whether a practice was functioning as a patient-centered medical home. And it was leadership among the 3 services, and up here basically felt that was the one that was the most we've had the most experience with, and it was so it's been rolled out with that recognition process, and we're setting a level 2 or 3 as an NCQA level as our target to get to have our practice evolve to that point and enroll as many of our patients in those level homes as we can. And all the services have committed to striving to meet targets. And right now we're in the process of just initiating the recognition process, but we've had estimates of our homes and their levels, and you can see in that chart basically where we see ourselves now, where we see ourselves evolving over the next 2 years. And we're ahead of schedule, basically about 24% ahead where we thought we were going to be at this point in time, and we'll be getting. We just completed a self-assessment, and we'll get a little better idea of where we're at with specific levels of enrollment and medical homes. Next slide. As I mentioned, we chose the NCQA recognition levels, at least at this point in time, and we're using it currently. The 2009 standards will evolve to the 2011 next year. We just completed a baseline self-assessment of actually all of our practices have been completed, and what do you want to get a good handle on where we were now. So we asked them to be as honest as they could manage to be, and really assess how they were performing, and because we want to basically understand at this point in time where we stand and where we're going to evolve, and then link performance, and we'll talk a little bit about that in a minute, about and be able to measure practices that may perhaps exceed 1 or 2 elements in the medical home, and see how they perform on linked outcomes, and learn from that as we kind of move it forward and share those practices with each other. Our plan is to, as I mentioned, we've done the self-assessment, just completed that. We're basically in the process of evaluating those and rolling out an educational program in the NCQA certification process across the MHS this year. And we plan to at least try to anticipate formal recognition in about 48 to 50 practices over the next between July and December of this year. The next slide, 14, is just the 2009 elements. Again, as I mentioned, that's what we're currently using. That's what they use for the self-score. That will evolve into the 2011 elements, and so and you're all probably pretty familiar with those. Next slide. Next slide basically talks about the measures that we're currently using and plan to use to measure output from our homes. And I think the key is worth kind of spending a little bit of time talking about these because they're very much consistent with where we saw our challenges, and we also be aware of and measure these things as well. So it's a combination of what's practical, but also where we think the greatest challenges are. We talk about, Yamal talked about access to care being a major issue and probably a source for dissatisfaction, as well as continuity. And so we embrace the primary care third available appointment metric for both routine and acute appointments, getting timely care rate, so patients' self-rate of access from their perspective, and then looking at primary care workload that's gone elsewhere from the medical home and looking at how we're doing recapturing that. We have a metric to look at that promotes patient-centeredness. Here is mostly the focus on continuity, measuring how often they see their PCM or their PCM's team, and again measuring the patient satisfaction with health care. Again, that area that we saw that we had some challenges in. Looking at the healthcare costs from the medical home perspective, again looking at the PMPM type of modality, but particularly centering on recapturing patients that have gone elsewhere, especially utilization for emergency rooms for primary care etiologies or diseases, and recapturing that, minimizing that where at all possible. And then looking for other modalities of perhaps overuse of utilization or urgent care centers or preventable hospitalization, so on and so forth. And then finally, very important on the readiness aspect is how are we doing preparing our providers, how do they feel that they're doing being able to practice to their license and measure their satisfaction with this, and so there's a primary care staff satisfaction metric. Next slide.
So this is Admiral Hunter. I'll jump back in here for a second and just a couple of amplifying comments on the slides that Dr. Kugler just went over. Definitions of access metrics vary system by system, but we have a category of urgent within 24 hours, routine within a week, and wellness visits within 4 weeks is in general. And behavioral health visits, if not emergencies, are treated as the within 1 week standard in our system. So to give you a sense on that, we did find that the customization or branding by service was important. It's very important for people to have ownership of this. So many of you may say, gee, they have a great advantage. Corporate puts out this policy and everybody salutes and falls in line. Well, it's not that easy. You know, medical staff are medical staff, whether they're wearing a uniform or a suit, and everybody values their autonomy and their service-specific culture and their ability to customize solutions that they think meet the needs of their patients. So the service branding we found was important. And we did provide investment capital and training to the practices that we're transforming. So we are now on a slide entitled Expanding Medical Home to Improve Performance, and we put this arrow in to sort of say there's a couple of ways that one could look at success. How would you define success? And you could define success in certain settings by managing to wellness or stability some of your most complicated patients, and that is a strategy we're embracing in the care that we purchase. But in the direct care side, in the side where we run the hospitals and clinics, our goal was to improve the experience and sort of the performance of care for all patients. And so we took the tack of transforming the practice to a patient-centered medical home, and all patients who were enrolled to the practice whether they fit in the diabetes registry or not, got the medical home services. And we looked at the literature and said, if we're having problem with these metrics, satisfaction, timely care, continuity, and ER utilization, how many patients do we have to enroll to get those metrics to green if every practice were able to achieve the average level of improvement that seems to be cited by the literature? And the answer was 2.5 million. So it's ambitious, and we did need to enroll a lot of patients if we were going to move the average patient to the right in terms of the performance of the system on their behalf. One of the things that we found when we looked in the literature is that the improvement is modest. So you expect, a few percentage points improvement in satisfaction and timeliness and continuity, not a doubling. And you initially think when you read about this model, it's so intuitively satisfying that, oh gee, it should be doubly good. So with that said, we have had some early successes, and I'll let Dr. Kugler talk a little bit about those, and then I'll take the performance issues.
So we were able to, again, we had some early adopters. We're on slide 17 right now, and we'll just kind of go over some of their results. So, one of the earliest adopters is right here in National Capital area at the General Medicine Clinic at Bethesda, and they found early on that they saw improvements in their HEDIS performance, particularly in the cancer screening area. They also saw an improvement, that's NNMC. Okay, they saw some improvement in their PCM continuity, increasing about 90% over a year's time period, 56 to 75% of time a patient would see their own PCM. And then they would also see, they also noticed improvements in some disease-specific or evidence-based guidelines. So improvement in asthma performance, and I think something's missing on the last slide there. I think that was a decrease in the A1C level.
Yeah, okay.
Yeah.
So that decrease 39% is not in their HEDIS adherence, it's
right.
In the A1C.
Right, yeah. So the, and then Edwards Air Force Base, the Air Force had initiated a programmed rollout of the medical home actually about 2008, 2009, about the time that the Bethesda model came up, and they kind of rolled it out to some of their family practice clinics, and have been gradually rolling it out over the past 2 years. And so one of the early adopters, Edwards Air Force Base, also reported improvement in PCM continuity, improvement in satisfaction with health care, and also improvement in A1C and LDL. So improvement kind of across the spectrum of both satisfaction and in quality and in evidence-based care that we were kind of expected to see, but this kind of confirmed that. Next slide. The challenges.
Okay. So we still have some challenges. So even in our most mature practices, and that is that patients still seem to express the need for immediate care and visit emergency rooms too often with primary care sensitive conditions. Things, to give you a sense of what these things are, many are respiratory infections. We have a lot of musculoskeletal complaints that we see end up in emergency rooms or departments when we feel like they could be handled with primary care. And we thought that having 3 appointments available in the next 24 hours would make a difference in that, but over 50% of our clinics now can offer 3 appointments within the next 24 hours. So, Mrs. Kugler, we can give you 10, 2, and 4 tomorrow, but that doesn't seem to satisfy the need. And the ability to self-schedule, which some have touted as practice that was successful in other industries. We have that with our Tricare online portal. You can go in and view all the appointments. We don't have them all enabled, but a robust selection of appointments and schedule yourself for something that's convenient, and it still is not, for some reason, satisfying the need. So we need to understand that better, what's driving people to emergency room care. In part, our patients are not penalized for seeking care in the emergency room. They have very little or no copay depending upon their category of patients. And it may just be that we've put in the carrots, none of the sticks. For us, we have to go back to Congress to get authorization to change the copay structure, and so far they haven't been open to that given how they see the stresses on the military population today. We also think that there are issues, though, with saying one is available for consultation after hours and really being available after hours in a meaningful way. And so we need to look at our incentives for providers and practices to really provide something other than some sort of limited telephone coverage after hours. We have some prior experience with nurse advice lines, although we're re-examining that. We have secure messaging in more and more locations where the patient can asynchronously message the provider. We tend to use Relay Health a lot, although we have a couple of other products. And we think that these will eventually make a difference, but it takes longer than we expect to create patient confidence in these tools so that they will not present for immediate care. And then in our private sector, you can go ahead to the next slide, we do purchase care on behalf of more than half of our patients, and as you saw from the first slide, not all of them are enrolled patients, but there's about 1.7 million enrolled patients who are potential to be in PCMH practices in the private sector. And so the first thing we did was go out and say, well, who can we work with and collaborate with in this endeavor? The difference over a year is remarkable, so congratulations to all of you who are on the line who are attaining certification, because in one of our regions we had, and our regions tend to be about a third of the country, we had 750 practices that had attained some recognizable level of medical home certification, and when we went back a year later, it was almost 7,500. So people are on this pathway, and we appreciate that there are partners to work with. Our goal in the care that we purchase is not necessarily to migrate all patients, but to find some of our highest users, our 2 or more chronic conditions patients, and we have that in our disease management database, and encourage them to be matched up with a private sector care practice that is in the medical home model. In order to do that, we're committed to paying for the extra management that will be needed. Things that we are looking at or participating in pilots in has to do with care management fees, additional fees for after hours appointing or availability, and some incentives for attainment of certain outcomes like HEDIS metrics. We also are looking at proposals to, we have a government-owned, partially government-owned outpatient electronic health record. We're working a proposal to provide that to some practices in return for them agreeing to enroll a certain percentage of our patients in their medical home practice, and also to share data across a health information exchange. And we would also be looking at other incentives that we might be able to provide, including things like subscriptions to secure messaging for practices that didn't have that. So we're looking for ways to encourage collaborators to see our patients. We're going to wrap right up here and get to your questions. Our next slide just includes a screenshot of our personal health portal. We are trying to engage our patients in their own health. They can see their pharmacy profile and refill prescriptions. They can book appointments in selected clinics through this portal. They can get to the secure messaging, although that requires a separate log-on. And now they can see their labs. We put 5 years of lab results into the portal, so people can actually access their historical data, and they can download anything that's available through this portal through the blue button that you see there next to personal health data. So if they are seeing a provider who's not electronically connected to our system for a specialty consultation, We would hope that there's been some provider-to-provider communication, but in any case, the patient can print and bring along a portion of their record, which may help in continuity of care. So our way ahead on the next slide involves leveraging evolving technology and also leveraging patient activation, because we see a little bit of that as the missing ingredient here too. We talked about carrots and sticks, but also we need to engage patients and families in this effort. We have some complementary efforts that go along with the First Lady's initiative to decrease obesity, particularly in children, the Let's Move initiative to eat healthier diets, to improve our level of fitness, to reduce smoking and binge drinking. For example, we have a program called That Guy, which some of you may be aware of, but you might not know it's a DoD program. We reduces binge drinking in at-risk populations by about 11% in large groups. So we're pretty happy with that, because that it can be a problem that affects some of our youngest military personnel. We're also adding comprehensive medication management and looking at techniques for both shared decision-making and brief action planning for self-management support. So to have the patient put some skin in the game in ways that are positively engaging them in their health, rather than trying to create negative incentives by copays and cost shares. So our last slide, and we'll stop here for questions. We'll just leave this one up. We think it is critically important to know your mission, know where you're headed, to understand your end state, and to move sort of from plan to healthy outcomes. You know, we can change around our health plan or our coverage, but what we're really looking for is health and the meaningful incorporation of health IT, and then facilitating and incentivizing the change for practices who work with us, for our own staff and provider base, and especially for our patients, so we really get to the patient-centeredness. So I think that's plenty of talking on our part. We'd be happy to take questions, so I'll turn it back over to the moderator.
Hi, this is Leslie Reeder. I just want to make sure you folks can still hear me.
You sound great.
Excellent, thank you. Okay, so we do have a few questions in the box, and then we have a few folks that have raised their hand. So I'm just going to alternate back and forth. The first question we have is, what tool is used to define the scope of practice of PCMs? And it sounds like you're using MTQA. Do you have other tools that you're using besides that?
Well, we have a set of what we call core privileges. And so we define for a pediatrician, for a family physician, for an FNP or PNP, we have a standard package of privileges that we expect them to be competent.
Is that what you're referring to, or the medical home recognition?
Well, looks like the asker is asking specifically about the scope of practice of your PCM.
Okay.
So it sounds like the core privileges is
right. That's
right.
A bundle, so to speak. So we have a clear expectation.
Right.
Okay. And Mary Purcell, I'm going to unmute you, and you can go ahead and ask your question. Mary, are you there?
I'm here, but I don't have a question. It's okay. Thank you. You've answered
Oh.
them.
Thank you. Okay, we'll go back. So what special requirements need to be incorporated into an EHR to facilitate PCMH? And I actually have a corollary to that, which is Tricare reporting on all of the meaningful use measures?
Okay. So in terms of the EHR, we don't claim to have that issue completely solved. We do have an outpatient electronic health record, which we've had for many years. Like many, we also have a different system we use for inpatient, and both systems are visible to all providers. So we have, robust laboratory, radiology, pharmacy, result type data that goes back over 10 years in the system that all providers can access, and we have some limited health information exchanges. They're fairly robust with VA. They're very primitive with other systems. So we see that the ideal EHR for a PCMH would be more population health focused. So we're trying to modify ours so that providers can look at panels, they can look at their performance. We don't have a lot of prompts and reminders that patients are overdue for things. We are trying to build that into our Tricare online portal so that the patient would get an email reminder that they're overdue for something. But right now, it's we have some overlays with the integrated clinical database and our population health portal that allow providers to get to that information, but or the team nurse or the care manager, but it's more cumbersome than we'd like. It's too many keystrokes, and it's not intuitive. And in fact, pharmacy management as well. So for those of you interested in adherence, it is possible to know that refills were or weren't picked up, but it's not easy. And so we need that sort of, we need a better feedback to the provider on what to do and how patients are doing in order for them to manage their population. Is that fair?
Yeah, I think so. We have a pretty good foundation, basic foundation in the medical market and the meaningful use intent, but we've got definitely room to improve and mature that.
And yes, we will eventually be reporting on all the meaningful use standards. They do apply to us.
Yes.
We can take another question if you like.
Thank you. Kathleen Frost, I've unmuted your line.
Leslie, if you just read their questions from the question and not unmute people, it usually works better to do the written, so have people ask a question in the text box.
Wonderful. Thanks, Lauren. Okay, I'm still a novice at this webinar stuff. So do you have care managers that are actively managing patients at Tricare, and if so, how are they coordinating care with care managers at clinics or other facilities?
Yeah, we definitely do. We like to have more. Okay. And it kind of depends on the setting in which that is. For our wounded warriors, a major priority for care management, there are wounded warrior units and clinics, and with specifically advised or assigned case managers, and our case managers that are assigned for patients that are hospitalized with serious conditions and on their handoff. But we would like to have more case managers and care coordinators located throughout our clinics. And as we grow and kind of evolve in our staffing with these, that would be one of the areas where we see we would like to mature.
Right. So we don't have a standard position description, for example, for a health coach, although one or more of the members of the healthcare team may take that role on behalf of certain patients. So more complex patients, the nurse may take that. We have an expanded medical technician opportunity in the military, our hospital corpsmen and medics, and they may do that for other types of patients. And then there's special provisions for wounded warriors. We can take another.
Thank you. This is a corollary question, which is how do you see the role of medical case managers, especially in terms of managing costs, accessing and coordinating care, patient satisfaction? And I think that many of us on the phone are very interested in how Tricare looks at care coordination as a method for managing costs, especially.
Well, a couple of things. How would I answer that? We find that our criteria for case management outside of wounded warriors are not uniform, and we've identified that as a problem. So if you are a wounded warrior or a seriously injured service member or their family, There's a formula, you cross certain thresholds, you get a care coordinator, a case manager. They're there for consultation and to increase the service level to you in addition to coordinate care. They're not really, in that case, focused on cost. In the care we buy, we have criteria for case management, but we find they're not uniformly enforced. And in some cases, they're more focused on sort of the medical necessity review and whether pre-authorizations are complete. We have not had great success in having them partner with a primary care manager, and I think that that's an area we've recognized for the future as we attempt to identify these patients with 2 or more chronic conditions and say this meets the threshold for case management. We need to figure out how the case management, which we purchase separately, is linked up with the private sector care PCM. And then the other thing I would say is we make some extensive use of case managers for children with special needs. And they do even expanded case management in that they also would coordinate community and educational services on behalf of the child.
Great, thank you so much. Let's see, there's a direct care question here. In Tricare markets that have multiple services providing primary care and that are dense with beneficiaries, has there been any discussion about how to cross-level patients between these primary care practices according to geography or patient acuity rather than consumer preference? I.e., are you assigning patients to practices versus letting them choose?
Well, patient choice is pretty much a fundamental part of the benefit. So we got to offer services and communicate availability and so forth.
Right, but your point is well taken because let's take the pediatrics example. If you have a healthy child, we would see that very appropriate for that child, for example, to maybe have a nurse practitioner for their primary care manager. But our leadership has felt that patients should weigh into that. So medically appropriate, but the mom comes in and says, I only want a pediatrician. I don't even want a family physician. And we struggle with that because we would rather use the pediatrician, to talk about practicing at the top of their license for the kids who most needed it. And so those gates are only controlled by availability. Once the pediatrics practice is full, then we say these are your choices. But it is not as medically stratified as it might be. Medical needs stratified.
And it's just,
well, we don't want to. Go ahead.
This system is unfortunately not robust enough, currently anyway, to be able to give us a good timely.
We have some fledgling experience with health risk appraisal, which may be a tool that we would eventually use to try to do a little bit better on matching.
Right. That makes sense. So I don't want to take up any more of your time. We're scheduled until 4 today. I want to thank you so much for joining us in this presentation. There have been quite a few questions about whether or not we'll make the slides available, and I believe we'll be able to do that, right?
Sure.
And wonderful. And the one last thing I wanted to mention is that the PCPCC does have an upcoming conference, another stakeholders meeting in October, October 21st, and please check out the PCPCC website for more information on that conference. So thanks very much again to Admiral Hunter and Dr. Kubler. It's just been a great pleasure. We do have more questions. We'll send them your way if you'd like. If you had the time to answer them, we'll make sure to post those answers up on the website for the PCPCC. So thanks again.
Thank you very much.
Thank you. Out here.